Hey, my beautiful dental squad. Welcome back to another episode of Mission MDS 2024. So, in this episode, we are going to see about a very important topic from oral medicine and oral pathology point of view, that is pre-malignant lesions. So, we'll be discussing a few MCQs also. So, do stay till last and let's just begin with our topic today, right? So, what we'll discuss is we'll discuss some oral cancer basics so that we will not miss any uh, even a normal minute MCQ also. And I've written HPV vaccine because in the latest times, HPV vaccine is becoming more popular. So I think it is better to know about a few points of HPV vaccine. So since it is trending, maybe they can ask a question on NEET MDS or INI set. We cannot say that. So, and also pre-malignant lesions. So we have 4 pre-malignant lesions, that is Leukoplakia, Erythroplakia, Lichen planus, and oral submucous fibrosis. Lichen planus we have discussed in the previous video, that is mucosal lesions. I'll give you the link. You can just revise it once again. And OSMF also we have discussed it previously in a single video. So in that we have even discussed about a case clinical scenario also. So that also I'll give a link so that you can just go through that. So let's just go into the epidemiology of oral cancer. So oral cancer is considered as the 6th most common cancer in the world. So this is important. So you know what is the first most common cancer in India? Do comment in the comment boxes below. Just comment me one thing. What is the first most prevalent cancer in India? Okay. Which is more prevalent in men and which is more prevalent in females? Okay. So do comment your answers below and let's just check your knowledge on oral cancer epidemiology. So it is more common in men than in women. So the incidence varies by geographic location. Yes. So with higher rates in South Asia, Southeast Asia, and Eastern Europe. So incidence is increasing in some parts of world due to the factors such as increased tobacco use and also HPV infection. Okay, so these are the main causes which are causing increase in oral cancers nowadays. So the cause, oral cancers, you have to remember 6S as the risk factors. Okay, this is the risk factors which are involved in oral cancer. Okay, the 6S are: S is for alcohol, smoking, the dietary habits which include spicy food, and also one more thing, it is UV exposure. UV exposure which is sun, right? So how many S's are done? 4. So one more thing is bacteria, especially syphilitic infections. Okay, syphilitic infections. And also one more S. What is it? I've told you 5 S's. Let me know the 6th S also. So also HPV, gender, and age are also some of the causes for oral cancer, right? So let's just see a few points on HPV vaccine. So it is a measure against human papilloma virus. Yes. So it is used against HPV to reduce significant risk of infection. So including oral cancers. So vaccine is recommended in both males and females, which is administered before the onset of sexual activity. So it is actually administered before the onset of sexual activity as far as CDC recommends. But if you have not taken HPV vaccine, you can take a HPV vaccine in adult age also. but that also has a minimum age bar for that. So yes, CDC recommends that 11 to 12 years olds gets 2 doses of the HPV vaccines, with the first dose at 11 to 12 and second dose at 6 to 12 months later. Okay, and it also says that if first dose is given before age of 15, only 2 doses are required, right? So this is the important points around HPV vaccine you have to keep in mind. So this is the chart that the CDC has recommended. So if the age is like 9 to 26 years and they have taken a first dose before 15th birthday, 2 dose series have to be given. Okay, 6 to 12 months after first dose. And if they have not taken the vaccine, like in some of our cases, you can go for 3 dose series. Okay, first at normal, and again 1 to 2 months you can go for one more thing, and at 6 months one more thing. If you are above 26 years, so you have to consult with the physician and then to take a call over it whether to take it or not. Okay, and above 45 years it is not recommended. Okay, so this you have to keep in mind. Then coming to, yes, again the risk factors. So yeah, so we have discussed six S is the risk factors for oral cancer. So a sore that does not heal, white or red patch on lips, gums, and inside the mouth, bleeding from the mouth, swelling of the jaw, loose teeth, difficulty swallowing or speaking. So you know, consumption of tobacco, that is spirit, right? Excessive consumption of alcohol, sorry, smoking, excessive consumption of alcohol, that is spirit. Then chewing betel nut without or with tobacco. Yes, this is one more. HPV, long-term oral cavity injury, people with a history of cancer, then exposure to harsh sun rays and unhealthy diet, which includes more of spicy foods, weak immune system, which includes syphilitic this thing, and family history of oral cancer. So what is the sixth S? So the sixth S is presence of sharp tooth. Okay, so this is the sixth S. Okay, you now got the six S's, right? Okay. So let's just dive into the topics of premalignant lesions. So let's just first see about leukoplakia. As you know, leukoplakia is a white patch. It is a clinical term which is used to describe white patch or plaque that cannot be scraped off. This is important. That cannot be scraped off is a very important thing, and cannot be attributed to any other known disease entity. And clinical representation, white patches or plaques on the mucous membranes of the oral cavity. They may vary in size, shape, and texture, and they are often asymptomatic, but become symptomatic if they are ulcerated. Okay, and if there is any dysplasia or malignant transformation associated. Okay, then these are the various sites where we can see the leukoplakia. So you can appreciate leukoplakia on tongue here, buccal mucosa here, and leukoplakic lesion on the linear on the gingival this thing, like see. So these are some places where leukoplakia can occur, and you have seen the presentations. So risk factors. The risk factors include tobacco use, both smoking and smokeless form of tobacco, and alcohol consumption, particularly when combined with tobacco. Chronic irritation from rough teeth. This is important. Okay, for leukoplakia, chronic irritation from teeth or ill-fitting dentures and other mechanical factors are very important factors which contribute to leukoplakia. Okay, and also HPV infection, right? Then so yeah, so we have types of leukoplakia. We have homogeneous type and heterogeneous, non-homogeneous type. So homogeneous, which appear flat white lesion that I have shown you in the previous photographs. Non-homogeneous types, there are of 3 types. That is speckled leukoplakia, nodular lesions, and verrucous leukoplakia. Okay, so the speckled leukoplakia you can see in this, appreciate the same in this image here. So here you can see the lesion, right? It is like a speckle, like small, small, tiny dots. Whereas nodular, you can appreciate big nodules, right? So this is nodular type of leukoplakia. Whereas coming to verrucous leukoplakia, whenever you hear a word verrucous, remember that it is the aggravated form of the lesion. Whatever lesion it is, okay? Verrucous term describes that it is aggravated form. Okay, so you can see how it is aggravated, like how far the white patches are, right? So this is verrucous leukoplakia. Okay, so you have to remember these types of leukoplakia also, and you can just go through that, like, so these are the important points clinically you can have, and you can just go through the histopathological points also, but that are not that important. Okay, so histopathology of leukoplakia include epithelial hyperkeratosis, as you can see in this image, dysplasia, and presence of keratin plugs, right, and inflammatory infiltrate of lymphocytes, right? The management is risk factors have to be eliminated in the patient, and surgical excision or laser ablation may be indicated when the lesion is dysplastic or suspicious lesion. Okay, so this is the brief about leukoplakia. A variant of leukoplakia, that is oral hairy leukoplakia. Oral hairy leukoplakia is commonly associated with HIV AIDS. Okay, it is associated with HIV AIDS and people who are with weak immune systems. So it causes white patches which are corrugated. So this is important. So white patches which are corrugated or folded in appearance are oral hairy leukoplakia. Hair-like growths may also be seen. Okay, so it is associated with Epstein-Barr virus. So this is one more important thing. Okay, then coming to the histopathological features, even histopathology of oral hairy leukoplakia is important. So a prominent confluent parakeratotic conified layer is seen. So you can see the thickening hyperkeratosis and conified layer here, right? So this kind of layer is seen in oral hairy leukoplakia. Okay, a subcorneal horizontal band like array of large ballooned epithelial cells. So you can see large ballooned epithelial cells here, so with pale eosinophilic cytoplasm and a clear pernuclear halo is seen. Okay, then mild papillary acanthosis, and also hyperkeratosis and marked parakeratosis of the superficial epithelial layer may be seen. Then cowdry type A intranuclear inclusions can be seen. So you can see here. Okay, so these are the important points around this thing. Then coming to erythroplakia. Erythroplakia is a clinical term which is used to describe red patch or plaque. So, okay, it cannot be attributed to any other known disease. So, erythroplakia, as you know, bright red patches. So, okay, the lesion often have a velvety or granular surface texture. They are typically asymptomatic but may become symptomatic if there is associated ulceration. Okay, so you can see the erythroplakic lesion here. Then coming to histopathology, there is epithelial dysplasia, of course, and you can see the dysplasia, how far it is, right? Then carcinoma in situ is seen. Erythroplakic lesions may show features consistent with carcinoma in situ, which is also known as intraepithelial carcinoma. So then coming to along with this, there is one more thing. This is presence of atypical cells is also seen. Okay, so they may reveal enlarged nuclei, prominent nucleoli, and abnormal cytoplasmic features. Okay, so these are important features around erythroplakia, right? So then let's just go into the variations, like differences. So leukoplakia, it is solitary white lesion or plaque anywhere in the oral cavity. Erythroplakia, multiple red solitary red plaques anywhere in the oral cavity. Histopathological variations is hyperplasia of epithelium is seen in leukoplakia and hyperkeratosis to varying degrees, and carcinoma in situ. whereas in erythroplakia also varying degrees of dysplasia and carcinoma in situ is also seen. Okay, the risk of carcinoma in leukoplakia is 5%, whereas in erythroplakia is 50%. Okay, then coming to OSMF. So betel quid chewing is the important factor you have to remember in OSMF. That is, and also areca nut. Okay, areca nut is also important. Other factors include tobacco use, consumption of spicy foods are the other um, factors which may exacerbate the condition. Then nutritional deficiencies, genetic predisposition, and autoimmune factors also contribute. So the symptoms include trismus, which will be progressive, that is inability to open the mouth. Burning sensation in the oral cavity can also be seen. These are the main factors which we see clinically. Then appearance is pale and blanched. Okay, there may be visible fibrous bands or ridges if it is advanced lesion on buccal mucosa, palate, and tongue. So, as the disease progresses, patients may experience difficulty in speaking, swallowing, and maintaining the oral hygiene. Right? Then, I'm not discussing exclusively OSMF because I told I have a video already up in the YouTube, so you can just go and check that video. So this is how the OSMF looks. You can appreciate the decreased mouth opening, right? Then the histopathological examination. So it is not that prominent, but you can see fibrosis of the submucosal tissues, which is characterized by deposition of collagen fibers and hyalinization. An inflammatory infiltrate may be present, which is consisting of lymphocytes, plasma cells, and fibroblasts. The epithelium may show varying degrees of hyperkeratosis, acanthosis, and atrophy. So one more important thing is OSMF is a potentially malignant disorder. Okay, you have to keep this in mind, with a significant risk of malignant transformation into oral squamous cell carcinoma. Okay, with a significant risk of malignant transformation into oral squamous cell carcinoma. Right? Then, so these are the varying histopathological variations how OSMF looks. So they might not ask, but you just go through. That's it. Okay. Then, okay, coming to management. Early stages, we have to stop the habits and take nutritional supplements. And the moderate stages use conservative treatment like intralesional injections. The intralesional injections which we use is hyaluronidase with dexamethasone. So which is an important. Okay, it is an effective treatment for grade 3 type of OSMF. Then topical hyaluronidase can also improve symptoms faster than steroids alone. And advanced stages, we use surgical interventions. Medications which we use are like steroids, pentoxifylline and antioxidants, omega-3, colchicine, allicin. Okay, these can help in OSMF symptoms, getting the OSMF symptoms uh, into control. And lycopene is effective for long-term treatment. Okay, so and aloe vera we can use to relieve burning symptoms of the patient. So this pharmacological aspect and management aspect of OSMF is also very important. They might ask a question from this slide also. Okay, so let's just see the question now. A 50-year-old male presents with progressive difficulty in mouth opening and a burning sensation in his mouth. So on examination, blanched patches are noted along the buccal mucosa and palpation reveals palpable fibrous bands bilaterally. The patient admits to a history of betel quid chewing for several years. Which of the following is most likely the diagnosis? So yes, you might have arrived at the answer. It is OSMF. Okay. So everything is present in the question itself, right? I need not explain this also. Then coming to another question, that is a 60-year-old female presents with a white non-scrapable patch on the lateral border of the tongue. The patient reports with no associated symptoms but admits to a history of smoking for the past 30 years and occasional alcohol consumption. What is the most appropriate next step in the management? The options given are observation and regular follow-up appointments, topical corticosteroid therapy, surgical excision of the lesion, immediate referral to an oral surgeon for biopsy. So before doing anything, I think whenever it is a non-scrapable patch and any patch in the oral cavity which you feel like it might be a potential cancerous patch, you have to take a biopsy. Okay, so that is a key point you have to remember. Okay, taking biopsy is very important. Okay, so that is so in this question also we have to advise the patient to take biopsy and refer the oral surgeon immediately, right? So if you like our video, do subscribe and do share it to your peers. We'll see you in the next video. Thank you.